Thank you very much. Good morning. It's a big pleasure to be here back in India with the eCancer team. And you have had a lot of Queen's oncology today, Dr. Berry, Dr. Booth, and now me. So we have worked. Oh, this is navigating by itself. Okay, so I have no conflicts. So you must have seen different versions of this slide showing how big the problem is in low and middle income countries about cancer. You must have seen different versions of this slide showing, although we have the significant burden, we are not doing too many trials in low and middle income countries. And you may or may not have seen this slide. This is a little old slide, but the context is very important here. This is about non-communicable diseases as a whole, not just cancer, but this was the number of trials that are being done that inform the evidence based on the Cochrane review, and the number of participants. That blue bar is not low-income countries, that's the high-income countries. The low-income countries is this one, this tiny. So these are the how many trials and how many participants contribute to our evidence base. So if you look at the number of participants, this is the total Cochrane for non-communicable diseases. Number of participants from low-income countries is 982. That's less than one trial. So we know that we have a significant burden. We know that we are doing less trials, and this shows what's the extent of that difference. We are doing 2 less trials. That means all the guidelines that we have about how to treat cancer, they're almost 100% based on participants not from our part of the world. So we are treating our patients based on evidence not coming from our part of the world. So that's a problem we need to fix. And when we say that, people make an argument that yes, of course, clinical trials is important in our part of the world for different reasons, but we don't have the resources to do that. We can't invest in clinical trials. It's expensive. I would argue that it's exactly opposite. We cannot afford to not make, thank you. To not make cancer control our policy agenda, because of course we have this burden of cancer, and effective policy is data driven. Data comes from research and trials. So in fact, it's the opposite. We cannot afford, it's far more expensive to not do clinical trials in low and middle income countries. But the problem is all trials are not created equal. That's why this theme comes into play, the theme of choosing wisely. And the theme of choosing wisely, I believe, should be extended to clinical trials as well. We should not be doing just any random clinical trials. We should choose our trials wisely. And that's where the title of my talk comes from. How do we choose the best standard of care in our randomized trials? I'll start with an example. This was published in Lancet Oncology in 2017. This is a trial of melanoma, the NEMO trial. And as you can see, they randomized patients between 2013 and 2015 to binimetinib, this new drug, or dacarbazine. Dacarbazine, I have never used that drug because my era started with immuno-oncology, ipilimumab, nivolumab. There's dacarbazine for melanoma. And this is a randomized trial from 2013 to 2015. For context, EP was approved in 2011. This is the seminal paper in 2011 June published in New England Journal of Medicine, which changed the standard of care. And then this trial was using dacarbazine as the control arm. No patients outside of clinical trial would have received dacarbazine. And the first principle of clinical trial is no patients should be willingly harmed as a result of participation. These patients were being harmed because they were getting dacarbazine. So the problem is, and as I said, it was approved in 2011 March, and this trial ran 2 years later. So the patients in the control arm, they were deprived of the best upfront treatment. And this marginal benefit that we saw for this drug was versus a optimal comparator. So we do not actually know whether that drug is a good drug. So the question is, whenever we're thinking about a clinical trial, doing a clinical trial, reading a clinical trial, the first question to ask is the control arm appropriate? And the control arm may not be appropriate. And there are 3 ways in which the control arm may not be appropriate. One, we may be using a control arm that is already proven to be inferior, similar to what I showed before, dacarbazine. The other is the trial may be saying, oh, we are allowing treatment of physician choice in the control arm, but they might be limiting the options so that the actually good drug may not be used. And the third is they might be using placebo instead of an active comparator. And if you want to learn detail, we have actually written a paper about this. If you read this paper, we give examples, but just to give a context for each of these, using inferior control treatment. So you might know that for non-small cell lung cancer, especially if the PD-L1 is more than 50%, the standard of care is immunotherapy, pembrolizumab. This was shown in 2016, received approval from the FDA in 2016 October. But this trial, cemiplimab trial, exactly same patient population, PD-L1 at least 50%. This trial ran from 2017 to 2020. And of course, they could not run it in US because everybody would get pembrolizumab there. And they had a chemotherapy control arm. So imagine this, you have a PD-L1 of more than 50%, you have non-small cell lung cancer, you participate in a clinical trial and get chemotherapy, because that's how the trial was built. And the FDA actually approved it based on this trial, although no US patients were enrolled. So this is the example of how we are knowingly using inferior treatment that we already know. What's the purpose of a trial? It's to find out whether the experimental arm is better. We already know the answer. The other example about not allowing an effective drug, this is the Olympiad trial, olaparib in germline BRCA mutation positive metastatic breast cancer. And here it says patients were assigned to receive olaparib or standard therapy with physician's choice. And so you might think, okay, that's appropriate. Physician can use whatever they want, but physician's choice is limited. Capecitabine, eribulin, or vinorelbine. They specifically did not allow platinum. We know that platinum is better agent for BRCA mutation positive cancers. They did not say we did not allow platinum. They said we allowed any of these three agents. So that's an indirect way of saying no platinum. And finally, using a placebo control when active treatment is the standard of care. So this is, again, olaparib example. This is in pancreatic cancer, the POLO trial. And here you can see that there is some significant benefit in PFS. But in this trial, patients were randomized to receive olaparib or placebo after they were on 4 months of FOLFIRINOX. Now, if a patient is, and they had to be responding, they were not progressing. So if a patient has metastatic pancreatic cancer, is responding to chemo for 4 months, then do you suddenly stop it and put them on placebo? No, but that's what they exactly did here. And no surprise, OS was negative. Look at the other graph. Overall survival, it has not even buzzed. These are the same lines, but they also say quality of life was maintained. This is a fancy way of saying quality of life was not improved. It does not sound nice when you say was not improved. It sounds nice when you say it was maintained. AKA not improved. And so basically, this is a drug that does not improve how patient feels or how long patient lives, but it costs more than $12,000 a month in the US, $70 to $100 a month in Canada, and has important toxicities. But when these results were published, I did not want to take names. It does not matter who said it, but what KOL said is, it should, it's not like could or may, it should become a new standard of care. And then truly remarkable. So this is our definition of truly remarkable in oncology. And then this is really exciting data, very excited. And look at this. It is our duty to search for this mutation. It is our duty. That means if you are not doing it, you are failing as an oncologist. Your license should be revoked. It is your duty. That's why you should be very careful when we are listening to KOLs and editorials. So who will control the control arm? Who is going to take that responsibility? And this is not like, there are several examples. Both of them are our papers. The first one in which we talk, maybe the control arm should come with an expiration date because they expire as new treatments come, but we continue to use the same control arm. In prostate cancer, it has been egregious. Patients have failed on abiraterone, enzalutamide, but they continue to receive the same treatment as the control arm. When we make these arguments, some people say that, okay, but because of the trial, at least some patients got the new drug. Let's say that cemiplimab trial, at least half of the patients got an immunotherapy. They would never have got an immunotherapy if there was no trial. So can access to the new drug in LMICs justify conducting a trial that would not have been ethical in high-income countries? But the answer is no, for two reasons. One, the Helsinki Declaration, the principle of trials, it says use the best standard of care. It never says use the local standard of care. And the other is there is no guarantee for continued access to treatment after the trial is complete. So several LMICs participated in that semiplimab trial. The trial completed, semiplimab got approval. But are patients getting semiplimab now? No. So it's just a matter of, the trial may be 300 patients, 150 will get the drug. And out of 150, your countries, your patients, there might be 2 patients, 3 patients. Does that justify subjecting all of them to a drug just for the sake of getting the drug approved elsewhere? And actually, this was investigated. This was a brilliant paper. I'm a big fan of this paper. I did not do it. This is my paper. They looked at all these trials that LMICs participated in to get a drug approved in high-income country back in FDA. And then they looked at whether these drugs are available in those LMICs that participated in those trials. And within 1 year of it being approved in US, 13% of high-income countries had access to the drug, 0% of upper middle-income countries and low-middle-income countries had access. Within 5 years, almost half of the high-income countries got the drug, but availability in LMICs was less than a quarter. And this is the graph that segregates by the geographical region. You look at Africa, up until 5 years time point, it's basically 0. So that means African countries are participating in a trial, in several trials to get the drugs approved in US, and up until 5 years, the availability of that drug in those countries is 0. Okay, we talked about appropriateness of control arm. It does not end when the trial ends, because the control arm means what happens after the trial as well. There is the role of post-progression therapy and crossovers. I might not have time to delve in detail, but just to give one example, the Mona Lisa trial, ribociclib trial for hormone-positive breast cancer, overall survival was a key endpoint, and they showed significant benefit in overall survival, unlike palbociclib. And they were arguing that this is a really good drug because it showed overall survival. But if you look at this first row here, this is the patients who got any medication after progression. Remember, this is first-line hormone positive. In hormone positive breast cancer, you have like 10 different drugs, right? So, but there are almost 25% patients, 1/4, who did not get any treatment after they progressed in first line. This is hormone positive. This is not like triple negative. They got 0. Of course, you will see overall survival benefit because the patients are not getting anything after the trial. If you divide by geography, actually you see that it was quite significant benefit in Asia, right? But in Europe and Australia and North America, it was crossing the confidence interval of 1. Hazard ratio of 1 was being crossed. So it was significant in Asia. It is highly significant in Asia. It's not significant in Europe and North America. So one could argue that probably the Asian patients are the ones who did not get any post-progression therapy. And that's why the whole benefit is being driven by this subgroup. But that's a hypothesis because we have not seen the data. They do not. Actually, I know that Dr. Cerny from SME-MCBS group, they emailed this trial is to ask for that segregated data, and of course they did not provide. And then there is a role of crossover. There are 2 issues with crossover. One is there should be crossover, but they did not do it. The other is there should not be crossover, but they did it, and both happens. So this is the case of evratron in prostate cancer, metastatic castration-sensitive prostate cancer. When this trial was done, we already knew that evratron was the standard of care in castration-resistant prostate cancer. So this is basically like doing a first-line trial when we already know that it works in second line. So in that case, the placebo arm, if they progress, they should get evratron because it's already proven. But if you look at the percentage of patients who got evratron in the placebo group after they progressed, it's this. So this is like, this trial answers nothing. We already know that evratron is a good drug in prostate cancer. What we need to know is giving it earlier better than giving it later? And that question is not being answered here. And the other example again from prostate cancer, this is where crossover should not have happened, but happened. So this is Sipuleucel T for castration-resistant prostate cancer. And this is the first time this drug was being tested. This drug had never been tested before. So this is stipulation T versus placebo, and they mandated a crossover at disease progression. That makes no sense because this is a new drug. If you progress, you want to get a drug that is already established, like docetaxel. But by mandating crossover, patients in the placebo arm, they did not get an effective drug like docetaxel up until later. So effectively, we are delaying the introduction of an effective agent. So this is where crossover should not have happened. What happened? Yeah, I have discussed this. So how frequent are these problematic trials? Like crossover happening where it should not have happened and using substandard control arms. Vinay Prasad's group looked into this and they found that these are the trials that led to approval. Other trials that failed, it might be much worse. But even those trials that led to approval, 25% had substandard control arm, 14% had errors in crossover. So what do we do? How do we move forward? In this Nature Cancer paper, we had discussed some key criteria for thinking about clinical trials in LMICs. First, they should address a question of important clinical need in the country. The unmet clinical needs should be backed by good evidence, and the trials should ideally assess interventions that are cost-effective and straightforward to apply, and they should be easy to conduct within the normal settings of standard care. To give an example, let's take the example of COVID-19. Now there is a drug called remdesivir which was tested. Mortality benefit was marginal. It costs substantial. It's not available globally. But then there was the recovery trial of dexamethasone. Mortality benefit was substantial, thanks to UK. Cheap and affordable, and it's available globally. So these are the type of dexamethasone type trials is what we need in global oncology. We don't need remdesivir type trials. And there have been a number of such trials, and Tata is taking a lead in that. These are the examples of several trials that I think are quite meaningful for low and middle income countries. And at ESMO of this year, Dr. Bardway presented this trial of peritumoral local anesthesia infiltration prior to surgery in early breast cancer. These are exactly the type of trials that we need. What we don't need is trials of Me Too drugs. Yeah, you may not even be able to say that these are two different drugs. One is sorafenib, the other is regorafenib. It virtually looks the same. This is for hepatocellular cancer. But having said that, I think there is some role of Me Too drugs in the context of low-income countries, because we have seen several trials coming from China of these newer Me Too-like agents. And that's the sintilimab trial that was rejected by the FDA in lung cancer. This was the trial of aumolertinib. This is a Me Too version of osimertinib. But I think this might have a role because we have seen that when these locally developed Me Too drugs are introduced, they're introduced at a very low price, and that drives competition, at least in low-income countries, so that over time, not only the price of that product, but the competing product, like in the case of ecotinib, which is a Me Too of erlotinib or gefitinib in lung cancer, it drove the price of all of these molecules down in China. But what's the solution? Can we do those unethical inferior control arm trials for the Me Too drugs then? I think the way forward is non-inferiority trials. In this context, I'm a fan of non-inferiority trials because you could do a non-inferiority trial of Me Too with the standard. In the case of cemiplimab, let's say you could have done a non-inferiority trial of cemiplimab versus pembrolizumab. So that way the control arm does not get disadvantaged. And the other role of non-inferiority trials in our context is to test de-escalation strategies. And you have heard from Dr. Tanak about this, Dr. Booth, from Dr. Booth about this earlier. Is a lower dose enough? Is a shorter duration of treatment enough? Is a lower frequency enough? So this can be tested very easily in the setting of non-inferiority trials, and those are the type of trials that we need. And of the policy changes that we need to make, I think I'm a big fan of empowering our patients with education because they are the ultimate stakeholders. And if they come to us and say, I'm not going to participate in this trial, then of course we'll have, like nobody will have any option. So we should empower our patients. But the bottom line is we should ask how to do right and appropriate ground shot type trials, the moonshot type trials, and what investment is required for that. Is it a priority in a local setting? I don't think there is much point in LMIC doing a phase 1 trial of a cancer drug whose phase 3 will be run elsewhere. It will be approved elsewhere and will continue to be unaffordable here. would the resources be better spent elsewhere? Is that the best use of our resources? And I think we should avoid trials just for the sake of doing trials, just to say that I have done a trial. The trials should be meaningful. And this spirit of choosing wisely should extend to trials, not only choosing treatments wisely, we should choose our trials wisely. And I'd like to mention acknowledgements, especially today, because I'm speaking here in front of all my mentors and people who have highly influenced me, inspired me. And Dr. Booth is my mentor. Dr. Berry is my mentor right now in Queen's Oncology. He's our department head. Dr. Richard Sullivan, I met him first in 2015. I think he forgot that in ESMO meeting, and he has been quite influential. I have been heavily inspired. And Dr. Tanak, we all grew up reading his lectures. Like this common sense in oncology, it did not come from us. We have been inspired from people like who are speaking today in front of us. And as a young colleague, I think we should all aspire to learn from them. And thank you for not sleeping like Chris Booth.